Right. Good afternoon, everyone. Welcome to October, and October's Grand Rounds. This is my name is Payam Nahid. I'm the Executive Director of the Institute for Global Health Sciences. So welcome really to our 2025 to 2026 Grand Rounds programming. This is a launch of it. You will have seen some messages, Friday messages from us about how we're reprogramming some of the scientific engagements and conversations that we hope to have over the next 12 months with you. We welcome feedback. We're just trying to increase the discussion, conversation, dialogue around science and collaboration. So you'll be seeing more of that. Because very much at a time of constriction, we at IGHS are expanding our network of global health scientists at UCSF and abroad, and trying to bring the science and community together. Part of the work is really all about making more space for collaboration. We have started this IGHS Connect, which is this is a part of the IGHS Connect, a branded effort to just increase dialogue around global health sciences. And this month we're celebrating Women's Health Month, which in the US is usually May. But I did a quick search, and actually in the UK they're having Women's Health Week, which is a big event. It's like I was surprised. It's held at the Barbican Centre in London. And there's a lot of people there. So we're aligned there. That's next week if you want to fly out to London. This week we have, coming up, we have a global partner spotlight, which is part of the IGHS Connects series. Our upcoming global partner spotlight will be Dr. Mutsa Bwakura Dangarembizi, who is an associate professor of pediatrics in the University of Zimbabwe, and they'll be speaking with us about their work in women's health. And then the IGHS Bixby Maternal Newborn Child Health Center is having an open house October 29th at 12 p.m. So please come to that. We're having these open houses where it's very conversational. You spend time with the center and get to know their work. And hopefully it spurs, again, collaboration. So today we're welcoming Dr. Nadia Diamond-Smith and Dr. Christine McDonald. Nadia, I'm sure you're all very familiar with. She's IGHS core faculty, associate professor of epidemiology and biostatistics. Christine, Dr. McDonald is associate professor of pediatrics and also in the Department of Biostats. And they're going to share their latest on nutrition and maternal health in South Asia. So with that, thank you very much. Welcome.
Thanks so much, Payam, and thanks everyone. It's great to see you here today. So Christine and I are going to go back and forth a little bit here and talk to you about some background about South Asia, why we're working in South Asia at the intersection between women's health and nutrition, and then a new project that she and I are partnering on, which we're very excited about. So yes, women and children's health, women's empowerment, nutrition in South Asia, changing landscape of micronutrient supplements, and then our new R01, new-ish, 1-year-old, still feels new, in Nepal. So just kind of setting the landscape and thinking about South Asia. One of the things that really drew me to this topic is this idea of South Asia being the Asian enigma. And so South Asia is a rapidly developing region. The GDP of South Asia is about twice that of Africa, which I know Africa is very big, but Africa as a whole. And it's home to 25% of the world's children, yet 50% of the world's wasted children live in Asia, right? So we see this conundrum, right? It's rapidly developing, has a higher GDP, and yet more children with poor health indicators. Women also have very poor health indicators in South Asia. We're going to talk about a number of different things, but I think a good marker of that is very low BMI for women throughout their life course. And I really love this graph. It's from 2015, so it's a little old now. And this shows the fraction of women over the life course who are underweight in India compared to Africa. And we can just see that, almost 50% of women are underweight, declining a little bit as they age, but very different than what we see in other parts of the world, right? And so really, what's going on here? How is women's health, children's health, development, how are these all intertwined? As some other indications, child health is also very poor. So as we said, as a large proportion of the births in the world quarter in South Asia, and about 50% of live births in South Asia are small or vulnerable newborns. So this includes preterm births, small for gestational age. And you can see here on this diagram from the Lancet, that blue is South Asia, and you can really see what a large proportion of, what a large number of preterm births are in that region. And over half of neonatal deaths are attributable to being small and vulnerable newborns. This is a really important contributor to poor health and mortality among children. And layering on top of that, we know that South Asia has some of the lowest indicators of women's status and empowerment globally. I also just want to stop here for a moment and thank IGHS for supporting the photographer who came to one of my projects in India and took all these beautiful pictures, which are from India, even though we will mostly be talking about Nepal. But that was really great. And these come from another project of mine in Rajasthan. So while, again, sort of a surprising conundrum, we see relatively high levels of women's educational attainment, yet low labor force participation. So women are going to school, more and more girls are getting educated, and yet that isn't translating into economic opportunities. It has one of the highest rate of child marriage in the world, and a very short interval between marriage and the first birth. All right, I'm going to hand things over to Christine to move us into nutrition.
All right, so I'll talk a little bit about women's nutrition and nutrition in general. And there are many ways that gender inequality can also influence a woman's nutritional status. We know that women who are marginalized often lack access to high quality health services, or that if they do have access, the quality of those services might be poor, might be expensive, and might make it difficult for them to obtain the care that they need. We also know that oftentimes from sort of a policy perspective, programs that are targeted towards women may receive suboptimal levels of funding or lower levels of priority, and that can affect also the care that they receive, both for health and for nutrition. And then from kind of a dietary perspective, and this particularly in South Asia, women often eat last in their households or their family, and they might eat the least amount of food. So other family members will be prioritized before themselves, and that the nutritional quality of their diet can suffer kind of as a result. We know that undernutrition, whether it's macronutrient or micronutrient undernutrition, can have consequences really across a woman's life and across the life course, and even influence future generations. Adolescence is a period of rapid growth and development where nutrient requirements are really elevated, and it can be really difficult for an adolescent girl to meet those needs. And if those needs aren't met, then her own health can suffer. We'll be talking about the preconception period, and this being kind of this really kind of critical window of opportunity to improve a woman's nutritional status before she becomes pregnant. And we really, it's a kind of a time period where there's this opportunity to have a great impact. During pregnancy, of course, nutrition is vital to the woman's own health and will also really influence the health of the growing fetus and the infant at birth and throughout infancy and childhood. And, undernutrition really at all of these different phases can have many adverse consequences, which are shown here. So, this is kind of the framework that we're working with here. Now, transitioning a little bit to micronutrients. So micronutrients, you may or may not be familiar with the term. It really refers to essential vitamins and minerals that we need to obtain from our diet and are really critical for human health. And micronutrients are really important for fetal growth and development, and then in infancy and childhood. And micronutrient inadequacies or deficiencies can lead to really critical health risks for infants. So they are associated with increased risks of low birth weight, of preterm delivery, and being born for small for gestational age. And Nadia showed you the slide from the Lancet, which just shows the burden of these conditions in South Asia. So taking kind of a closer look at some of the data on burden and on prevalence of some of these conditions, we're looking at anemia here. And you can see here that actually the prevalence of anemia among women of reproductive age in South Asia, this is the Southeast Asia, according to the WHO, there's 200, the prevalence is 47%, and that translates to 256.6 million women who are anemic. So that constitutes 40% of the global burden. And if we look historically over the past 20, 30 years, the prevalence has really remained unchanged. If anything, it's actually increased in some countries in South Asia in recent years. So anemia has been a really tough nut to crack, and we know that anemia can have a lot of consequences for women, for their children, and also for kind of countries' productivity. We look at developmental indicators, and anemia is really important from that perspective as well. But anemia is not just that's not the only nutritional indicator that we should care about. There are many other micronutrients, that play a really important role in women's health and nutrition and in fetal growth and development. It's also likely that if a woman is deficient in one micronutrient, she's probably deficient in other micronutrients. So for example, if you're deficient in iron, you're probably also deficient in zinc and possibly B12 and a whole bunch of other micronutrients that are really important. And there haven't really been a lot of efforts to quantify that and really capture that burden of multiple micronutrient deficiencies until recently. So this is a really nice paper Gretchen Stevens did with a whole collaboration of folks using data from many different countries, and she was able to look at the prevalence of micronutrient deficiencies among preschool children and women of reproductive age by region and then globally. And for women, she focused on iron, zinc, and folate deficiency or insufficiency using survey data from that measured biochemical indicators of micronutrient status. And you can see here that in South Asia, 74% of women were deficient in at least one of these micronutrients. But that's crazy. That's a lot of people. 307 million women just in South Asia who are suffering from micronutrient deficiencies. So what do we do about it? What do we do to improve micronutrient status? And, of course, we advocate for improving dietary practices, improving food security, making, trying to break down the barriers that currently limit dietary intake in many contexts. But for these particularly kind of critical periods of a woman's life, and particularly thinking about preconception, pregnancy period, and adolescence, the nutrient requirements are so high that it's really difficult to meet those requirements just through diet alone. And we know that because in high-income countries, we recommend women to take prenatal vitamins, right? We actually recommend that if women are planning to become pregnant, they actually start taking prenatal vitamins in that preconception phase. So supplementation is really an important strategy when it comes to kind of micronutrient health of a woman during these critical periods. So that brings us to multiple micronutrient supplementation, or MMS. And this is, well, not so new, but a supplement that contains 15 essential vitamins and minerals for pregnant and lactating women, and it meets the micronutrient requirements that poor diets can't meet. And most of the micronutrients are in about one recommended dietary allowance, so you can see the different micronutrients here. And there's kind of over the last maybe 10 years, been a kind of a shift in the policy landscape in many low-income countries towards from iron and folic acid supplements to MMS. So that we're starting to see a change that more and more governments are recognizing kind of the value of MMS over IFA, and are kind of trying to roll that out and scale that up. So there are significant benefits of MMS in comparison to IFA. So obviously it contains more micronutrients. It does include iron and folic acid, but it includes 13 other micronutrients that are important. And as I said, that, you know, the guidance is shifting. There were two kind of really important papers that came out in 2017 and 2019 that used data from multiple trials that really provided sound kind of confirmation that MMS is both effective and safe. And, you know, from a policy perspective, we were waiting for that kind of the clarity of that evidence to become available. And now we're seeing, like in emergency settings, MMS is recommended in patients with tuberculosis. Interestingly, the WHO only recommends that MMS be used in the context of rigorous research. And I think many people in the nutrition community would argue that that's way too conservative. And many country governments have actually kind of ignored this and are, if they have the resources to be able to do this, are switching from IFA to MMS and really kind of rolling that out nationwide. It's a small number of countries, but there's been a lot of advocacy towards that. And importantly, MMS is included now in the WHO essential medicines list, which is important kind of from a sort of a systems level and kind of programmatic level of actually getting MMS to countries. And there has been some research just to show that switching from IFA to MMS will reap a lot of benefits kind of in the long term. So one analysis showed that this transition can avert over 250,000 child deaths and nearly 25 million disability-adjusted life years lost over 10 years. And that's just assuming a coverage of 30%, which is about what IFA coverage is right now. And if that were to scale up, then there would be, you know, really remarkable benefits. But that MMS is for pregnant and lactating women, and that is, you know, what IFA and what MMS currently, you know, the programs focus on the provision of these supplements to pregnant and sometimes lactating women. But we know that in South Asia, more than half of women don't actually, they may not know that they're pregnant, and they may not choose to engage with the health systems until their second trimester of pregnancy. And which means that we're missing out on that first trimester in those first 6 to 8 weeks when the neural tube is closing, and there are a whole bunch of other really important fetal development kind of processes that are happening that are dependent on good nutrition. So, you know, thinking about that, how can we kind of take advantage of this critical window of opportunity? So by intervening in the preconception period, we're laying that kind of foundation and the groundwork to improve the woman's micronutrient status. So she's entering pregnancy with a kind of improved micronutrient status, and then hopefully a reduced risk of neural tube defects and many other kind of adverse birth outcomes. So I'm going to hand it back to Nadia.
Great. Thanks, Christine. Also, maybe in the questions, if anyone wants to hear more about fortification, that's another area of Christine's expertise where she has a lot of projects and does really interesting work. So thinking about everything we've been talking about and thinking about the preconception period and women's status and child health and in South Asian context, you know, what I really see is the nexus of these factors, empowerment, nutrition, health, is young, newly married, preconception women. So shifting our focus a little bit to Nepal, this picture's still from India, but the average age of marriage is 18 for women in Nepal. And 50% of women are pregnant within 1 year of marriage, right? So we see that there is a very narrow window where women are sexually active, might get pregnant, and before they then get pregnant, where we might be able to intervene. And this, while some other work that I'm doing and others are doing is trying to help women who want to delay the first birth be able to do that, the fact that this window is so narrow actually provides an opportunity when thinking about something like supplementation, right? Because there's a pretty defined period where we can start reaching people. Most marriages in the context that we're working are still arranged or at least semi-arranged, which is where families or other people in the community are contributing to the choices of who marries who. And why this is important is because this means that often partners and also households don't know each other very well before they get married and start living together, which also makes things around women's status and women's decision-making power in the household more challenging. But there is still predominantly the tradition of co-residence, where women move into their husband's home at the time of marriage, and this is often can be in a different village or district or state. And this is important because this puts women at an additional disadvantage in terms of, they're in a new community where they don't know people. the health system might work slightly differently. They don't have other social support or connections in their communities that can help them be able to get health care, seek care if they get pregnant or want to become pregnant or want to avoid becoming pregnant. And as I said, co-residence is common, so women are often moving into their husband's family homes, although with time this is becoming less common, and also couples do move out as they age. And so bringing these things all together, we can see that young, newly married women often have very low status in their households. They might not have a lot of decision-making power. They might not have a lot of social capital, social connections, good communication with their husbands and family members yet, because they're just getting to know each other. And as Christine mentioned, some of these markers of status are clear in patterns around who has access to food, how much food, when they're eating in the household. So this really presents what we see as a gap and an opportunity. We know that, just to kind of bring this all together, women's status in their households and community is low. This is associated with several poor reproductive, maternal, and child health outcomes. This is especially heightened in those early days of marriage. And this impacts the timing of pregnancy and nutritional status. So what we asked is, could the time of marriage be a really important and unique opportunity to improve women's health and set households and couples and women on a different trajectory, right? This is a time where new relationships are forming, and maybe, rather than so many of our interventions, we wait till people are pregnant or a few years in when patterns are already set. But maybe this is an opportunity to intervene early and set a different trajectory for how households are communicating and, women's access to health. And additionally, we know that the preconception period is critical for improving health, and it's often neglected, as most interventions wait to intervene until pregnancy, which, as Christine mentioned, is problematic because of late pregnancy care seeking. Also, a large number of pregnancies are maybe not planned or timed in this setting, as all is true all over the world. And then, of course, we also should be thinking about improving women's health and nutrition, not just because they might get pregnant, right? This is something that I think we often don't talk about enough, but we looked at that line initially on that early slide. Across women's life course, women have many poor markers of health, and of course we want to be improving women's health and nutrition outside of just the fact that you might get pregnant. So with this in mind, and this was in partnership with our co-PI in Nepal and local partners in Nepal, we developed an intervention called Sumador, which means best relationship. And it's a 5-month weekly group intervention for newly married women, their husbands, and their mother-in-laws. So this little diagram shows that there's the 3 people from each household triad, and they come together with other members of their community. And really the idea here was to get at individual, household, and community level norms and practices, because one thing that I was really struck with some work I did in India 15 years ago, where we were trying to improve iron folic acid uptake and improve knowledge about green leafy vegetables and all the things women are supposed to eat in pregnancy. And I just kept hearing women say, yeah, I know I'm supposed to take IFA or eat green leafy vegetables, but my mother-in-law and husband don't know, right? And this, I feel like, it's great to be empowering the individual, but in this setting, and I think a lot of settings around the world, decisions are made at a household level and are made with a partner or are made in different ways, and we often neglect that. And so our idea here was, can we address these individual, household, and community level norms? And as I said, this was co-designed with our partners through a 5-year, a different grant, which involved formative work where we did qualitative interviews with women, husbands, and mother-in-laws, and then additionally a longitudinal study. And through that and through like a lot of meetings and workshops, we developed this intervention, which includes a lot of interactive activities and games to provide information, but it's really aiming to start building relationships and breaking down social and gender hierarchies and norms and get people to start talking to each other and knowing each other. This was our list of topics. As you can see, we do talk about nutrition, but there's a lot about healthy marital relationships, showing you care, talking to each other, talking about reproductive decision-making, gender inequality, and then, intimate partner violence, a whole host of things. And we kind of go back and forth between the nutrition, the reproductive health, and then just sort of the gender side of things. We piloted this with 30 households in 2021. Here's some pictures. It was like, I don't know if anyone, this was like the height of COVID in South Asia. It was like a year later there. So it was really amazing that this happened. And we weren't sure it was going to happen, but it was really incredible work with our team and all the participants. And that early work suggested, so we did both baseline and endline quantitative surveys, and then also qualitative interviews with participants. And so we found that there was again, this was pretty small because it was a pilot, but a significant change in the if people said that the household ate together most of the time or not. So you can see like an increase in the proportion of people who said that the household ate together usually or all the time, and a big decrease in the proportion of women saying that they always or most of the time ate last. And these were some of the big things that we were working on. And then here's some quotes. Here's a husband. Now, both my mother and my wife are trying to establish a good relationship. She's eating nutritious food and asks for help. In the earlier days, she didn't ask for help. We all eat together now. My wife eats more nutritious food like green vegetables, eggs, meat, cereals, lentils. We tell her to rest. And here we see a woman talking about the knowledge that she learned. So I used to hear that to prevent an unborn baby from gaining weight, pregnant mothers were prevented from eating nutritious food and iron tablets, but I came to know these weren't true. We have to eat food and take rest. We also saw a big impact on people's relationships, which I was really excited about because, I think this is very interesting. So here we see a mother-in-law who is not the main target of this intervention, right? But talking about her own empowerment and how it changed her relationship. So going together with my son and daughter-in-law, I came to know many things. It was easier to go with them. I would have been too shy to talk if I'd gone alone, but I felt changes, even if it's a little. I'd always wondered how my daughter-in-law would be. She got recently married. I hadn't known her well. I got the opportunity to know her while going to the program. We used to talk together, talk on the way, discuss about things. After we'd come back, we perform work together. We share things. I had a negative attitude toward my daughter-in-law earlier, which has changed. My daughter-in-law treats me well, and so do I. And this is like my favorite quote ever because it's like, so I don't know. I think that, these kind of things are really important. And we think, women across their life course, right, are like, don't have the types of relationships and opportunities that they like. And anyways, and then here's a woman talking about, yes, there's been changes. Their behavior toward me when I was newly married has changed. I had to perform all the tasks by myself. Everyone helps with chores now. There's equal distribution of food. We don't fight. There's been changes in my husband and mother-in-law's behavior. Previously, my husband used to force me for sexual relations, and he doesn't do it now. He asks about my health. He respects me and loves me. I'm happy now. It's like anyway, so it's really exciting and promising, and we really wanted to continue this work more. And then I got to know Christine, and Christine told me about MMS and convinced me that we should integrate this with an actual micronutrient supplement. And we'll talk a little bit later on. We initially were going to do it with IFA, but we decided to do it with MMS. We applied for an R01, which is a 5-year grant from the NIH to test the impact of this intervention in a larger population. So our first aim is to estimate the effectiveness of Simidur on newly married women's anemia and micronutrient deficiency. Here's our primary micronutrients. The secondary outcomes we'll be looking at are related to reproductive, pregnancy, and infant health. And we're also going to look at the cost per disability adjusted life year averted. Our second aim is to try to understand the pathway, like why is it? Is it the MMS? Is it the amazing relationships that everyone's going to form by being part of this? Is it the knowledge they gain? So we'll look at changing norms, empowerment, nutrition, etc. Yes, delineating the pathways. And then we're going to collect longitudinal triadic interviews. So with a subset of participants, so all three of our household members, and interviewing them at multiple time points, again, to understand, like, in a more deep way, what's changing, what this, like, how this intervention might be changing or not changing behaviors or outcomes. So here's our beautiful conceptual model. So we see we both have combined the Sumidor intervention with the access to MMS, which we, hope that the increased consumption of micronutrients will directly increase micronutrient uptake and then anemia, but then also through a pathway of changing social and gender norms, women's empowerment, the household relationships and practices and knowledge, that those will change the diet and food consumption and also allow women to be able to take the micronutrient supplements. I'm sure Christine can talk more if you're interested. I think one of the things that was interesting about this, what we kind of propose, this package is, Christine said that, like, IFA is often like 30% rates of consumption, right? So even though it's very widely available, it's often not taken, even though it's free and given to women in their prenatal visits. And so, we hoped that some of these other behavior change types of interventions surrounding that would really promote uptake. And yes. So we're going to be working in 70 villages in each arm, 140 total. Each village has one group of women, so there's 700 women, 3 people per household, so that's 2,100 people, followed every 6 months for 18 months with surveys and then also blood draws, and that's been a fun new thing for me to learn about because I've never done a study that involved any kind of blood draws, so thank goodness Christine is here. And yes, and then we're going to be conducting these concurrent longitudinal qualitative interviews. And the eligibility is being married within the last 6 months, 18 to 25, not currently pregnant at the time of recruitment, the husband not planning to migrate, because this is an area with a lot of migration, and currently living with a mother-in-law. We're working in 2 provinces of Nepal. One is kind of in the plains area right along the India border. Like, from a lot of the villages, it's like India's like right over there. So they're very, very close to India, very similar to India. And then one is near Pokhara, so slightly more mountainy area. And we are implementing it in 2 phases, maybe 3. We'll see how it goes. One of the things that's very interesting about intervening with newly married women is there's like a distinct marriage season in Nepal as in India. So you really can only start, if you want people to have been married within a certain window, you can only really recruit at certain times of year, which has made it really challenging. We're going to be randomizing at the village level. And then the control groups will all get the intervention after the data collection is complete. So everybody gets it eventually, although they will not be as newly married at the time that they get it. We still think it's going to be very valuable. Were you going to talk about MMS? What was I going to talk about? I'll talk about MMS. Just a little bit about MMS. That was another thing that we had to try to figure out. So how to give people the MMS. So it's going to be provided to the intervention groups in person at 3 time periods in bottle form. There was a lot of discussion. People do a lot of research on if the bottles or the blister packet, what's the best way of giving people these type of pills so that they're more likely to take it. Some colleagues of ours are working in Nepal and have been doing some research on this and found that the bottles seem to work well. And we were lucky that we were able to get it donated by Kirk Humanitarian. And then how do we measure adherence? So weekly through the course of the intervention, as women are leaving the group, we're going to ask them just one question about how many tablets did you take in the last week? And then once a month, we're going to ask them to bring the bottle in so we can weigh it. But then the intervention ends, so we're not going to have as much contact with them. So we are planning to try to do monthly calls, asking them about consumption, and then the weighing of the bottles at each survey. So, unanticipated challenges, the best part of doing research. I'll let you take over.
So, as you know, as I mentioned, MMS, there's been this huge shift towards MMS for pregnant and lactating women, right? And lots of policy changes at that level. And there has been some research, kind of efficacy research, that has shown that MMS is safe and effective and improves micronutrient status among adolescent girls or women kind of in the preconception period. But not really, there's no programs or policies that provide MMS to women in the preconception period, kind of in real world settings. So that, in speaking with potential donors and speaking with potential partners, we've got some, well, why are you working, with preconception women, and how would this work in the real world? And well, there isn't a national policy for that. So that's been kind of a learning process that, I think even though scientifically, like and kind of theoretically, it makes sense, and from a biological perspective, there's a whole lot of rationale for that, the programmatic and kind of real world context is not there yet. And I think one of the really, frankly, the main kind of challenges in, if you're thinking from the national government's perspective, you have a limited budget. You're probably having to allocate more funding just from the shift to IFA, from IFA to MMS, because MMS is more expensive. It's already kind of been a challenge to do that and to deliver MMS through kind of antenatal care services. And now we're talking about, preconception women, like, wait, we're not there yet. So this has been kind of a challenge. And really, I think if we maybe had a little more funding, we would like to include a third arm, so that we could really kind of tackle that a little bit better. So, lessons kind of learned.
Like a third arm that was just MMS.
Just MMS alone, without everything else. Yeah. So then we can really attribute the difference, but hopefully the improvements that we see. Is it the MMS, like, that's really driving it, or is it the MMS plus all of these other kind of behavioral and educational things that we're implementing? In Nepal specifically, they're really just at this cusp of shifting from IFA to MMS for pregnant and lactating women. And when we started kind of the design of the study and started the kind of national IRB process and all of that, MMS was technically banned. So that was interesting to learn about, and we had to get a lot of special approvals from the government to use MMS for research purposes. So really, in the last few months, that has changed. It is no longer banned, and there's more research that is implementation research that is being done in Nepal to evaluate MMS and different kind of delivery platforms and all of that. But that's also been interesting. As Nadia said, Kirk Humanitarian, which is kind of an NGO that manufactures MMS, has really played a major role, like, globally in the shift to MMS. They donated the MMS to our study, which is great, but they would not ship it internationally, so they shipped it to my house. And then I went to FedEx and shipped like huge cartons of MMS bottles, like hundreds and hundreds of pounds. So that was also a learning opportunity. So yeah, and then, for me, I think one of the biggest challenges is just regarding the micronutrient status assessment. So we're at baseline 6 months, and then at the end of the intervention period, we're doing venous blood draws, and we're assessing many biomarkers of micronutrient status, and the kind of domestic capacity to do those analyses is pretty limited. The US CDC, when they do like the national micronutrient surveys, they export all of the samples out of the country for analysis because capacity is not great. So, but for research projects, they're really kind of strict guidelines on kind of exporting biological samples out of the country. And this is common in other countries as well. And is really kind of challenging because you want to ensure that like the QA, QC systems are in place, that you're going to, after investing all of this time and effort and collecting the samples, that they're going to be analyzed properly and you're going to have like reliable data. So we did identify a private lab and are working really closely with them, but it's been a lot of technical support and kind of developing the SOPs and getting everything in place. For the folate analyses, we are actually exporting those to India because there is a lab that's accredited by the CDC for analysis of red blood cell folate. Is really technically difficult to do. So yeah, but I think we're in a good spot. Okay, yeah.
All right, just a few more unanticipated challenges. So, another things that we've learned are about things that change as you move from a pilot to the larger randomized control trial. So COVID, I mentioned that we did our pilot during COVID. You guys all remember COVID. And, I was like, wow, it's so amazing. We were able to do this. And COVID, it's like, we could do it then. So it's like, it's going to be so easy to do it now. But it turns out maybe it's the reverse of what I thought. We found it a lot harder to recruit people. There's a lot more male migration right now. And now looking back, we're like, oh, maybe it was so easy and everyone came and there was like 90% participation rates because everybody was stuck at home and no one could migrate and no one had anything to do. And they were like, great, sure, I'll come to your intervention. So that's been a surprise. And it's been a lot harder to identify participants who are planning to be there, not move, et cetera. And then another change is that we're seeing some evidence that there might be some more rapid changes in demographic behaviors than expected, especially around co-residents. So our partners, as they've been doing the initial listing, there just seems to be a lot more co-residents, and this is where newly married women and husbands are living with the mother-in-law. And like before, that was not at all restrictive. Basically, every household with a newly married woman also had a mother-in-law, and that's not been the case as much. So again, we've had a lot of discussions, like should we loosen some of these, eligibility criteria that we had? How should we deal with that and think about that? So I'm sure we'll find more lessons learned. And then, of course, there's been some other things that have happened in the last year. So the marriage season is from like November to May. So in like May, we listed all the house. It was like all ready to go. And then the NIH, this is an NIH funded study, banned funding to go to our foreign partners. And this project, its cycle year was the end of May. So we all of a sudden found ourselves without money and without knowing if we were going to have money again. So that was pretty sad and scary. But then it came back. And so then in September, we were all ready to go. And I was supposed to go to Nepal and like everything was ready. And then there was like a revolution in Nepal and the government got thrown. And this is not the White House. I showed this to my husband and he was like, maybe choose a different picture because that looks like the White House. But this is the Nepal's Parliament building, which got burned on like September 12th-ish. So then that happened and everything was on hold again. But that was a very short overthrow of the government and things seemed to be calm. And so like next week, we're supposed to start again. Who knows? Hopefully the slide does not continue anymore. But fingers crossed that this will be just an exciting year that we can all move forward from. I just want to acknowledge our study team. Dilys is here also, who is a member, a co-investigator. Brinan, who's a new PhD student, who's going to be part of this project as well. Our partners in Nepal. Again, this is funded by NICHD. And thank you. If you have any questions.
The Zoom mics are on, so if you have a question, go for it. And we have one question on the I'll start out. The question is, have you considered smart pill bottle caps that count pills as kind of use as exercise?
Yeah, thanks for, hopefully everyone can hear me. That's a great question. We have talked about adherence, like assessment of adherence a lot. There has been quite a bit of research that have kind of validated different tools and different ways of asking kind of adherence questions and measuring them. I think for the scale of this study, the smart caps just weren't possible. I think there's probably, and I think other studies have tested them, especially for MMS use, but yeah, so we're not using them. We did consider them. I think we looked at other tools that have been validated and used in other contexts.
I have a question. And if you could repeat the question.
Oh, sure.
Are you doing anything with the mother-in-law's primary?
Okay, that's a great point. I mean, we definitely were not doing that, but it's a great idea. We are collecting data from the mother-in-laws, and I think are thinking about next how to, just given like some of those quotes and how valuable this was to them, and important. And, you know, we tried to ask them a little bit about like what they would want and what they'd want information. Also, I have another somewhat similar project in Rajasthan, which also involves mother-in-laws, where we more specifically have asked mother-in-laws, try to provide some health information related to the mother-in-laws, because they get an intervention on their own about like menopause and like other things that they're interested in. But it's an area that I think is it's like not a focus, right? Like talk about preconception, like nobody thinks about you once you stop having babies. I mean, you know, and so I definitely think it's something I'm interested in. I know others are interested in. I don't know. Did I not repeat the question? The question was, what about the mother-in-laws? You should also think about them. Sorry.
Yeah, great study. How do you find out mutual nature?
Our partners in Nepal, was part of sort of this like workshopping, developing the intervention, and there was a lot of different names and ideas that came about, and they suggested it and thought that it fit with the goals, and yeah.
Yeah, so the question was like if Nepal is planning to provide MMS, you know, kind of nationally or as part of their, you know, national policy, then why do this? So the national policy is really just MMS for pregnant and lactating women, nothing about kind of preconception women before they become pregnant. So that's what we're particularly interested in. And as to our knowledge, they're not thinking about the preconception women yet.
Thank you. It's an interesting study that have you seen the cost effectiveness of the MMS, and how about the intervention can be applied to the context like Afghanistan, where we have the P are around 6 to 7, and you see nowadays at least 74% So can we do such kind of intervention there, because the vitamin D deficiency 95%, other micronutrients are quite low. So what is your recommendation for such kind of
I'll start with the second question, which was how would something maybe,
of 6 and 7
yeah, how would this work in a setting with a higher TFR and
no utilization?
yeah. I mean, and so I think, well, so a few comments. Well, so Dilys and I and Christine have been trying to get funding and thinking about something that sort of bridged the gap between the preconception and continued with this type of a model of, like 2 microphones, this type of a model for merging it with like group prenatal care and like kind of setting a groundwork for helping people engage in healthcare in pregnancy, right? And theoretically, something like this, I mean, I don't know that list of topics. I know it was only up there briefly, but, you know, a lot of it is about getting women starting to think about when they do get pregnant or think they might be pregnant, you know, starting to go for their first prenatal visit early on in pregnancy. So part of the idea is to, you know, bring awareness to the importance of some of the care women maybe would be wanting to seek in pregnancy also. In terms of the fertility stuff, there are a number of sessions in this related to talking about family planning, and the actual original intervention was really sort of like half nutrition, half helping women delay the first birth. And then I kind of split it. So I have another RCT in Rajasthan, which is just focused on helping women who want to delay the first birth time their pregnancy as they want to, or if they don't want to delay the first birth, just time their pregnancy as they want to. And so I think that really fits, and then be talking about family planning for if they want to delay the first birth, or after the first birth want to delay the second birth. And so I think that's something which could easily be, I don't know as much about like time to first birth or like spacing in Afghanistan, but I imagine anything that brought those issues up sooner and helped couples start talking about them sooner. I think that's really like one of the critical parts of the household relationship side of things, is helping families be able to, what we found in some of the early work in Nepal in the formative study is that even 6 months or a year into marriage, like most couples, like we interviewed the husband and the wife, most of them said they'd like never talked about when they wanted to have their first birth yet, right? So like that kind of data was what really got me to think about, like, how can we, one of the activities intervention is like sit down and draw your timeline of like when you want to do various things in your lives, and then like talk to your husband about it, and so it's like simple things like that it didn't seem like couples had an opportunity to do and can make such a big impact on them having the life that they want. I'll let you go.
Yeah, so MMS is more expensive than IFA for sure. I don't have the exact numbers, but that has been, I think, one of the like factors that has constrained the transition, like at a government sort of policy level for, if you have limited funding that's available, how do you invest it? And like, how does the kind of cost benefit analysis shake out? There is a lot of evidence to show that the switch will pay off. And I think more recently, as the demand for MMS is growing, the supply is growing and prices are coming down, and there are have been new mechanisms put in place to help governments finance MMS, which is really helping. So like there's something called the Child Nutrition Fund, where it's kind of matching funds. There are nutrition commodities that are kind of included in this list, and if a government is committed, they can invest some money towards like this, particular nutrition product, including MMS. Then this funding from sort of philanthropic and some donor government funding can match that. So I think there have been kind of innovative approaches to bringing the price down and making it more feasible for countries to switch.
Great talk. Thanks very much. Can you explain why a country would ban MMS?
Yeah, so that I think it was an old policy that had been around for a long time, and it wasn't necessarily that this MMS was banned. It was a supplement for pregnant women that contained certain ingredients, just because it wasn't regulated. So they wanted to make sure like the only supplements that were being provided, like, through antenatal care, whatever, was IFA. And they kind of excluded everything else. And this was before this shift to MMS kind of was even a question. Years and decades ago. Yeah. So they realized that, oh, yeah, by the way, we have this outdated policy, and it turns out getting something like that, like nullified, is a little bit of a process.
Lucky for us, Helen Keller, HKI, has been like working really hard to get this on that issue specifically. So we just, we were so slow starting up, and they solved that problem for us by the time.
This is fantastic. Thank you for sharing. Could you talk a little bit just about who your partners are, how big a study team you have? I'd love to hear a little bit more about.
Okay, well, I can talk about, so our main co-investigator there is Mahesh Puri, who's runs an organization that mostly focuses on reproductive sexual health. He does a lot of work on abortion and women's rights and violence. So he's like me. And so this is a new experience for both of us, in that we neither of us had any experience with like blood samples or trying to do anything like that. So but his team has been working in Nepal, working with UCSF for 15 years on a number of different NIH grants. What, 30 years? Yeah, maybe, yeah. Okay, all right. Dillis knows the backstory then. And so he is like one of the, I mean, I was really spoiled because I did my K, which was my big first project. He was my partner, which I got connected through people at UCSF. And he's just so good, you know, he's like so amazing. And like the every single part of it, it's like a true partnership. You know, we really like co-developed ideas together. He leads the team. I'm not like hand holding anything, or, you know, I feel like all the feedback is like very thought through and collaborative. And he's, you know, he's done projects, like I've worked on the Nepal turnaway study, and he was our main partner there, that were in, you know, multiple different provinces all over Nepal and really remote areas. And he finds and trains people, you know, where like languages are different, where you need like young women to be going to talk to other young women, right? And I don't know how he does it, but he's really incredible. I don't know if you want to talk about our other.
Well, so for the micronutrient status assessment, we tried to identify many different labs within Nepal, and just tried to get as much information about them as possible and learn about like what external quality assurance schemes they participate in, look at papers they have published, to look at data, like looking at standard deviations of different measurements and things like that. And we did identify this private lab that has been really good to work with. And so like CREPA is kind of subcontracting with them, and then they've hired a team of phlebotomists that are going to the field. But, you know, it's like no small feat to collect blood samples in women's homes and then set up a field lab and, you know, centrifuge the samples and separate the samples and get them to a freezer and, you know, do all of that. And they'll be doing most of the analyses. And then we're shipping some of them to India. So, but they've been good. Yeah.
Sure, it's kind of an analysis question.
Ask us in 3 years.
Well, just thinking about your AIM-1, because it's your like nutritional status outcome, and I know it's randomized, so theoretically, like pregnancy, we would think that any difference in like anemia and pregnancy, which is during pregnancy, would be randomly distributed in the intervention control arms. But if your intervention arm could reduce pregnancy, then it has a potential modifying effect. So basically, how are you controlling for pregnancy in that primary analysis? If that makes sense.
Yeah, I mean, I definitely think that. Sorry, the question is about how we're going to account for the fact that many women probably will get pregnant in our analysis when thinking about anemia and micronutrient status as the primary outcome. Yeah, I mean, I think this is hard. It's really hard because our formative work found that 70% of women wanted to delay the first birth. And yet like 79% of people have had a baby after 2 years. So women were not able to do that in this setting. I mean, we do have this, that was not with our pilot. That was just the formative work. And so we think that hoping more women are able to delay the first birth in our intervention arm compared to our control arm. And yeah, I think we're going to have to figure out more about like trying to like separate out the two components. Right? We think that like anemia might be different, partly because pregnancy is delayed, and then partly because, our primary outcome endpoint is at 6 months officially for the anemia. So, you know, by then fewer of them will have gotten that pregnant, at least, even if they are already somewhat pregnant. So I think there it might be less of an issue, and like later on more of an issue. I know we're at time, so we can stop. We can talk. If you have any ideas, let us know.